Hi, welcome back to your prescription for medication education. My name is Yenmi, and I'm here to bring you quality information regarding medications and health-related topics. And today I'll be continuing my topic on obesity. Today's objectives are to identify and explain the weight loss targets, briefly cover what the surgical options are, and summarize the roles of nutrition, physical activity, and sleep in achieving and maintaining weight loss. I'm going to assume that you watched part 2 of my obesity video and just continue where I left off. So after the medical provider has diagnosed and determined the patient's ABCD stage, a personalized care plan is then initiated with the patient based on their preferences, capabilities, and ORCD, which helps ensure short-term and long-term goals are achieved. ABCD is considered a lifelong disease and requires ongoing management to prevent weight gain once the patient has achieved the weight loss necessary to prevent or treat obesity-related complications and diseases. The weight loss treatment plan can change over the course of treatment. Initial treatment may include surgery or higher doses of medications and more intense caloric restrictions. The maintenance phase may involve changes in medications, doses, and even cessation of medications such as antihypertensive medications that are no longer needed due to weight loss. The patient must be involved in this decision-making process to ensure the care plan caters to the patient's individual lifestyle and goals to ensure weight loss targets are met. The weight reduction target is based on the amount of weight that will improve the patient's obesity-related complications and diseases. The target is the percent weight reduction that has clinically meaningful benefit, which can be monitored via clinical, laboratory, or symptom improvements reported by the patient. Examples include reductions in waist circumference, decreases in blood pressure readings, improvements in A1C, and reduced pain in osteoarthritis. The specific percent of weight reduction depends on the complication or disease we are targeting, but the reductions can be categorized into 3 tiers. 5% or less is considered an incomplete response. Greater than 5% to less than 15% indicates a good response. 50% or higher is considered an excellent response. The degree of clinical improvement will not always match the percentage of weight reduction, and the healthcare provider and patient must keep this in mind as well. The goal is always to achieve enough weight loss for clinical improvements. The following data on this slide is based off the AACE statement. This slide represents the weight loss targets needed for clinical benefits to be seen in the various diseases and complications associated with adiposity-based chronic disease. The conditions in green require a minimum of 5% weight reduction compared to those in yellow, which require 7% minimum, and those in pink require at least a 10% weight reduction. The column on the far right simply represents that an additional benefit may be seen as the patient exceeds the weight reduction range maximum threshold. Let's take a look at 3 related conditions on this slide. In the green colored section, we can see that improved hyperglycemia only requires a 5% weight reduction to see improvements in diabetics. Now, in the yellow section, we require a more aggressive goal of 7 to 10% to prevent the patient from progressing from prediabetes to type 2 diabetes. In the pink section, we can see that if our goal is the remission of type 2 diabetes, the patient will need at minimum a 10% weight reduction. Various surgeries and procedures are available as an option for treatment, such as surgical sleeve gastrectomy, Roux-en-Y gastric bypass, 1 anastomosis gastric bypass, adjustable gastric banding, biliopancreatic diversion with duodenal switch, and intragastric balloons. Although the most common procedures are surgical sleeve and Roux-en-Y gastric bypass. A BMI of 40 or higher, or a BMI of 35 or higher with ABCD stage 2 or 3 may indicate a patient may benefit from one of these procedures. Various professional bariatric surgery organizations have their own opinions in determining when a patient is eligible for surgery. The image on the left is a sleeve gastrectomy, and this is performed by removing 80% of the stomach. The image on the right is a Roux-en-Y gastric bypass. This is done by dividing the stomach into a top portion about the size of an egg, which is then connected to the jejunum, and the larger bypass stomach, which is now excluded from the food pathway, is connected 3 to 4 feet downstream, which gives the bowels its Y shape. Patients should have access to counseling and support in order to create a personalized nutrition plan which adheres to the patient's cultural norms. If the patient and a medical provider choose to incorporate lifestyle modification in the form of diet alone, then a conventional caloric deficit of 500 to 750 kilocalories is recommended, or another approach is to use a fixed calorie limit. For women, the fixed calorie limit is 1200 kilocalories per day, and for men, it's 1500. The Body Weight Planner from the National Institute of Diabetes and Digestive and Kidney Diseases is a validated web-based tool designed to estimate the caloric needs for weight loss and maintenance based on patient-specific data such as weight, sex, age, height, and physical activity. I tried out the website myself and I think it's quite easy to use and allows the user to get an idea of how a change in their activity level or desired goal date affects the number of calories they should aim to consume in a day. With diet plans alone, the expected average weight loss is typically 5 to 10% of initial body weight over 6 to 12 months for most patients. This is an image of what the Body Weight Planner tool looks like. As you can see, the website is designed quite well and has an easy to use layout. In terms of dieting, there is no single diet composition that is superior for weight loss when compared to others. What has shown to be effective for weight loss is the patient's ability to adhere to the plan over an extended period of time. Safety data for the various meal plans is unavailable for periods extending beyond 3 years. However, only the Mediterranean diet has shown long-term cardiovascular risk reduction. Basically, the best diet is the one the patient is going to enjoy, that is safe, and is going to follow consistently. The Mediterranean diet is based on the traditional cuisine of countries bordering the Mediterranean Sea. The foundation of the diet is plant-based, not meat-based, and there is no single definition for it, but it often contains more servings of vegetables, fruits, whole grains, beans, nuts, seeds, and olive oil. Only moderate amounts of dairy, fish, poultry, and eggs are consumed, and red meat is only eaten once in a while, typically one serving per week or less. Exercise alone has a slight effect on weight loss. The estimated weight loss expected can range from 1 to 3%. However, incorporating an exercise regimen into the patient's weight loss program has a wide range of benefits besides the expected weight loss. It can improve cognitive function, it lowers the risk for death from all causes, it can increase self-esteem and reduce anxiety, it can increase muscle strength and increase endurance, it can improve the patient's quality of sleep, it can increase libido in women, and may reduce the risk for erectile dysfunction in men. A general goal for most patients is to work up to 150 minutes per week of moderate intensity aerobic activity, divided throughout the week consisting of at least 3 sessions. Keep in mind, this is a general recommendation and the patient should be advised to start with light activity and slowly increase intensity as they can. Whole body resistance training is crucial and should eventually be incorporated because it will help preserve the loss of lean muscle mass during the patient's weight loss journey. The patient should slowly aim to do 2 to 3 sessions per week. The patient should also be advised that once the weight loss target is met, they may have to exceed the 150 minutes per week of moderate intensity aerobic activity to about 200 to 300 minutes per week to maintain their current weight. Poor sleep quality can contribute to obesity. Disruption of the normal circadian pattern can lead to increased appetite, increased energy consumption, decreased energy expenditure, and cardiometabolic disease risk. Studies have shown a short sleep duration, which is considered less than 7 hours per night, is linked to higher BMI and increased waist circumference. This correlation is due to increased ghrelin levels, decreased leptin levels, impaired glucose tolerance, and elevated cortisol. Educating patients on the importance of proper sleep hygiene and its impact on weight management is recommended. And that was your dose for medication education. I do hope you enjoyed part 3 of my obesity topic. If you did, please give me a like and subscribe. And as always, I welcome any feedback. Thank you and have a great day.